Welcome to AETCM, the emergency medicine channel. Today let us discuss about one of the important endocrine disorder, that is thyroid storm. Okay. What do you mean by thyroid storm? What is your opinion about thyroid storm? Okay. Sudden excessive release of thyroid hormone. Okay. So production normally takes many days, but suddenly if it releases to your system, that produces an acute problem, that is thyroid storm. Okay. Hyperthyroidism means what? What do you mean by hyperthyroidism? The amount of hormone produced in our body is excess, that is hyperthyroidism. Thyrotoxicosis means that is acute. Thyrotoxicosis means that hormone has produced its toxic effect. Okay, normally you have, when your thyroid hormones are high, your heart rate increases. If it increases more than a limit, if the patient develops atrial fibrillation, supraventricular tachycardia, cardiac failure, then it will become thyrotoxicosis. Okay. So what are the causes for thyroid disorder? That hyperthyroidism. There are two important deficiencies in thyroid. One is hypothyroidism, other one is hyperthyroidism. All your metabolic activities are going to increase in hyperthyroidism. We'll see the causes. Graves' disease is one of the commonest condition which can produce hyperthyroidism, where you get enlargement of thyroid gland. That is very important. Enlargement of thyroid gland. Toxic multinodular goiter is another important cause that we have seen in many patients with enlarged goiter. But if you palpate the thyroid, that will be nodular. Okay. You can get multinodular goiter with or without toxic finding. With toxic finding means multinodular goiter is there, tachycardia is there, other findings of hyperthyroidism is there. Toxic adenoma, single enlargement of thyroid gland. Carcinoma, some mutation TSH receptor, struma ovary, these all things we will not discuss. The most important reasons in emergency room which patient can present with hyperthyroidism is Graves' disease and multinodular goiter. And the storm will occur suddenly if the hormone releases to your system, either after acute illness or a surgery of thyroid gland, that you can call it as thyroid storm. Secondary hyperthyroidism are not very common, that also we will not discuss in emergency room. So we go to the next slide. How do you remember the clinical findings of hypothyroidism and hyperthyroidism? You imagine that you are a normal human being. Whatever you have, metabolic activities, if they are increasing, you call it as hyperthyroidism. If it is decreasing, it is hyperthyroidism. Start from the brain. If you are mentally, you are becoming more calm or lethargic, laziness, then that is hypothyroidism. Whereas you are hyperactive, anxiety, fear, then it will become hyperthyroidism. Sir, like everything will increase. The two important things you should remember, one is heart rate, tachycardia and cardiac failure. Okay. When the heart rate increases, what will happen to your ejection fraction? Ejection fraction decreases because not the ejection fraction, the whole cardiac output actually decreases. That is because you need some relaxation time for your ventricle. That diastolic phase is gone. So tachycardia produces cardiac failure. Another one is high BP. These are the two important things we are worried in emergency room. Any patient with hyperthyroidism or thyroid storm, these two things are important for an ER physician, whereas other things are there, but that may not produce an acute problem. So cardiac problems are very, very important in thyroid disorder, whether it is hypothyroidism or hyperthyroidism. Okay. So what happens to the heart here? Tachycardia, palpitation, arrhythmias and hypertension. What type of arrhythmias are common? Atrial fibrillation and supraventricular tachycardia. These are the two important arrhythmias which are seen in hyperthyroidism. So some patients come to emergency room only with atrial fibrillation. If there are no other causes, we have to suspect hyperthyroidism. Okay. Now this is an important sign in hyperthyroidism. That is, you can see the both the, it's called as exophthalmosis. Both the eyes, upper part of this white sclera you can see in the upper part, white sclera in the lower part also you can see. So that is one of the important finding of hyperthyroidism. There are a lot of other findings can be there in hyperthyroidism. Unintentional weight loss is the most important thing. So thyroid enlargement can be there, ophthalmosis can be there, unintentional weight loss can be there, tachycardia can be there, atrial fibrillation can be there, cardiac failure can be there. So these are the common findings. Okay, increased sweating, all these things. Now, what are the important lab investigation you get in hyperthyroidism? When the thyroid gland is overactive, T3, T4 will be elevated. What happened to the TSH? TSH will be reduced. That is called as negative feedback. So, if the thyroid gland is increasing in its production, that gives a negative feedback to TSH production. And what happens to the TSH? TSH comes down. Okay. But whereas in hypothyroidism, what happens? T3, T4 is not producing. So that gives a feedback that T3, T4 is not producing. That give a feedback to TSH production center, and TSH will increase. Thinking that the production of TSH increasing, then the thyroid gland can function more. Okay. So here the most important investigation will be TSH. If TSH increases, that is hypothyroidism. TSH decreases, that is hyperthyroidism. And T3, T4 also can be increased. So T3, T4 increased, TSH reduced. That is hyperthyroidism. Okay, so that investigation, anybody who is having symptoms of hypo or hyperthyroidism, you have to investigate for hyperthyroidism or hypothyroidism. Suppose you have a patient admitted in ICU, unnecessarily if you are sending thyroid function test, it can produce some alteration. What it is called as? It is called as sick euthyroidism. Okay, patient is sick, admitted in ICU. Due to some reasons, their TSH or T3 can be altered, especially TSH. So, if you don't have any clinical suspicion on thyroid disease, whether it is hypothyroidism or hypothyroidism, unnecessarily sending investigation for thyroid function will be a problem in your management. That is called as sick euthyroidism. But here patient is admitted with tachycardia, cardiac failure, you are suspecting thyroid disorder, then you have to send a T3, T4 and TSH. What happens to TSH? TSH will be low, T3 or T4 may be high. Okay, that is hyperthyroidism. Now this is the chart which explains you what is thyroid function test in various type of diseases. We will not go to all types of disorder. One of the important thing we are discussing here is hyperthyroidism. TSH is low, T4 is high, T3 is high, primary thyrotoxicosis. Okay, just opposite that, primary hypothyroidism. What happens here? T4 is low, T3 is low, TSH is elevated. Okay. There is something called as subclinical hyperthyroidism. Subclinical hyperthyroidism means what? Patient does not have any clinical feature, but TSH is low. That is very important. Where is it? Subclinical hyperthyroidism. Okay. Subclinical. Okay. TSH alone is low. Okay. So what is the problem of this condition? This condition can present with osteoporosis. Okay. One of the organ system in our body which is going to affect by mild elevation or mild overproduction of thyroid gland is bones. Okay. So long-term subclinical hyperthyroidism can present with osteoporosis. Rarely they go to slightly higher T3, T4 level and they may go to tachycardia or atrial fibrillation. Okay. So isolated atrial fibrillation, always think about hyperthyroidism. Okay. So you understood what is the clinical investigation we do in a patient with suspected hyperthyroidism. Now, whenever patient, what are the clinical scenarios we can go? You can get hyperthyroidism case in emergency room. Patient is coming with cardiac failure. That is the most important thing. Patient is coming with unexplained atrial fibrillation. Patient is coming with unexplained supraventricular tachycardia. These are the three clinical scenarios you are going to get. So hyperthyroidism is equal to atrial fibrillation, supraventricular tachycardia or cardiac failure in emergency room. Okay, but post-surgical, especially thyroid gland surgery, that is expected complication of like thyroid surgery. That there also you can get thyroid storm. There also patient can have tachycardia, cardiac failure, all these things. Okay, why cardiac failure occur in thyroid disorder, hyperthyroidism? Because normally your thyroid gland controls your metabolism, whether it's a cardiac metabolism, liver metabolism, brain metabolism, everything is controlled by thyroid gland. If metabolism increases, what happens? Heart rate increases, the rate increases, diastolic phase increases. Slowly, patient will go to cardiac failure. Now, how do you? We already discussed that how to investigate. Lab investigation shows T3 or T4 may be elevated, TSH will be low. Okay. What is sick euthyroidism? We have already discussed that. Sick euthyroidism. What is that? Any patient who is admitted in your ICU, if you are not suspecting hyper or hypothyroidism, don't do the investigation. If you are doing it, it can show some abnormality in TSH or T3 that cannot be attributed to either hypothyroidism or hyperthyroidism. That you should remember. Okay. Now, symptomatic relief is the first one. What are the clinical findings of hyperthyroidism? Tachycardia, heart failure, palpitation, sweating, anxiety. Okay, these all are due to beta adrenergic overstimulation. So, what drug it can reduce all these symptoms? Any beta blocker can reduce the symptoms, but only one beta blocker crosses your blood-brain barrier. What is that? Propranolol. Propranolol is the only drug which crosses the blood-brain barrier. That's why we use propranolol in hyperthyroidism, migraine, all these conditions. We use only propranolol. So propranolol will be an ideal drug to control all the symptoms. But the only thing you should remember is in patients who is having already cardiac failure due to this problem, whether we can use beta blocker or not. Okay. So the answer is if the cardiac failure is due to tachycardia, you control the tachycardia, heart failure can become normal. Okay. So in this condition, we can use beta blocker for the treatment of cardiac failure induced by tachycardia. Okay. So that is the main problem. Can you tell one more condition which has got similar finding, endocrine disorder, tachycardia, cardiac failure, palpitation, sweating, anxiety, pheochromocytoma. What is the treatment there? There also treatment is alpha blocker with beta blocker. There beta blocker cannot be started as a first line drug. There alpha blocker has to be started, then beta blocker has to be added. So propranolol 20 to 40 milligram 6th hourly should be started. Okay. You can go for atenolol. The problem with atenolol is it will not cross the blood-brain barrier. So always beta blockers like propranolol is better than other drugs. Alternative drugs like suppose the patient is having asthma or something, we cannot use beta blocker, then verapamil can be used. That's a rate limiting calcium channel blocker. That also can be used. Now the second line, so why we have started propranolol? We have started propranolol to control the symptoms like beta adrenergic symptoms. But that will not reduce the hormone overproduction. So next will be reduction of thyroid hormone production. So that we have to see the most important drug is carbimazole. Methimazole or carbimazole is the most important drug that can reduce the production of the thyroid gland. So initially you may start 10 to 20 milligram 8th hourly and you can continue 10 to 20 milligram TID, then BD, then OD. It can be continued for nearly 1 to 2 years. Okay, if we are not going for definitive surgery, it can be continued for a longer period. Now, this is already we are told why we are starting propranolol, that can control the beta adrenergic overproduction, and propranolol already we have discussed that it can cross the blood-brain barrier. That's why we are using propranolol. But other beta blocker also has got similar activity. Only the anxiety part and that neuronal problem cannot be treated with other beta blockers. So other beta blockers or calcium channel blockers which can control the heart rate can also be used. Propranolol is safe in pregnancy. Okay, that also you should remember because pregnancy is one of the condition where you can get overproduction of thyroid gland and it can produce a lot of complication because of there are two lives in the body. Okay. Next one is carbimazole. Okay. Carbimazole, what is the action? We have already told. What is the action? Methimazole, carbimazole, it reduces the production of the thyroid hormone. Okay. Normally we start with TID dose. Then here the dose is 10 milligram TID we can start or 20 milligram TID. Then 10 milligram BD. Then it takes longer period, 10 milligram OD. Then nearly 2 years you continue, you can stop it. Okay. So that should be done if there is no surgical treatment for this patient. Okay. But acutely, you start with higher dose and slowly reduce the dose. What are the probable side effects of this drug? This can produce sometimes bone marrow suppression. So we have to be very careful when we are treating methimazole or carbimazole. We have to do CBC during the period, and rarely this drug can produce a granulocytosis. So that is very important thing. Whenever you are starting this drug in your ICU, follow-up should be daily. You have to do the thyroid function test and you have to do the cell count. Okay, these two things you should remember. And if the patient develops a granulocytosis, what will be the clinical finding? Neutropenia. What will happen to the patient? Patient can get infection before that patient develops oral ulcers. What is the typical feature of that oral ulcer? Oral ulcer without surrounding inflammation. Okay. So that is very important. If your cells are normal, any oral ulcer will have a surrounding inflammation. If your cells are very low, then there is nothing to produce an inflammation. So oral ulcer without inflammation is the classical finding in seen in a granulocytosis. Now, alternative drug for that is propyl thiouracil. This is a very useful drug, especially in pregnancy and breastfeeding. Whereas methimazole, carbimazole, we cannot use in pregnancy. So you can start 100 to 200 milligram TID, 100 to 200 milligram TID, and maintenance dose will be around 50 to 100 milligram per day. So same like previous drug, we can continue for longer period and taper down and wait for 1 or 2 weeks what happens and stop it and see what happens to the patient. Some patients may require longer period more than 2 years. Okay, but if you are going for a definitive surgical procedure, once you remove the thyroid gland, everything will become normal. Then the patient will go to hypothyroidism. Then you will have to treat that also. Now, thyroid storm, we have already discussed what is thyroid storm. Thyroid storm is acute release of hormone to the system. Okay, so suddenly patient will develop hyperthyroidism, where the patient was normal previously. Suddenly he develops an acute problem because of acute release of hormone to the system. There are two important storms. One is medical storm, other one is surgical storm. Medical storm is, you know, that any patient who is having thyroid disorder, suddenly after an illness like infection, stroke, trauma, diabetic ketoacidosis or an accident, post surgery, suddenly patient develops the surge of the hormone release can produce thyroid storm. Another one is after surgery of the thyroid gland, suddenly the hormone gets accumulated in the gland and released to the system. That also produces thyroid disorder, that is called as surgical storm. These are the two storms we should remember. The most common storm which come to emergency room is medical storm. Okay, surgical storm normally occurs the post-surgical ICU. Okay. Now the clinical features are same, but it is an aggravated problem of what we have seen previously. Suddenly patient develops tachycardia, atrial fibrillation, supraventricular tachycardia, cardiac failure, altered behavior, all these things. And investigation is same. What happens to the investigation? TSH will be very, very low. T3, T4 will be very high. Now, other two investigations I didn't tell that. One is a patient can have hyperglycemia. Other one is patient can also have hypercalcemia. But once you remove the thyroid gland from the patient, what is the common percentage of patient to the emergency room? Once you remove the thyroid gland, what is the common presentation to emergency room? That is hypocalcemia. Okay. Here, hypercalcemia can be one of the presentation and hyperglycemia can be one of the presentation that can be associated with hyperthyroidism. Now, the management we have already discussed, but only one important problem what we have not discussed in the previous scenarios, that is patient can have high body temperature. High body temperature, they require cooling. So you have to give lot of cool IV IV fluids to the patient to rehydrate the patient, and cooling blanket should be added to the patient treatment regime. And another important problem is infection. We have already seen that most of these patients are presenting to this condition because of they have some infection. So antibiotic therapy is very, very important. Another important problem we have already seen, atrial fibrillation. How do you treat atrial fibrillation in thyroid disorder? You start beta blocker, that may be enough. If it is not getting controlled, what is the best treatment option? Patient with atrial fibrillation with cardiac failure. What is the best treatment option? Digoxin. Okay. Digoxin at present we do not have IV digoxin. You can even start oral digoxin. Okay. So atrial fibrillation can be treated with either beta blocker or rate limiting calcium channel blocker or digoxin. So this is one of the indication for digoxin because most of these patients may have cardiac failure. So beta blocker cannot be used, calcium channel cannot be used. Digoxin is the ideal choice here. Another important drug we have already seen that is propranolol. IV propranolol is given in most of the standard textbooks. We do not have IV propranolol. So if you want have a better effect, you can go for IV diltiazem or verapamil. Okay. But what is the advantage of propranolol over other drugs? It crosses the blood-brain barrier, and patient will have like mental anxiety, fear, everything will be relieved. Propylthiouracil is another important drug. 600 milligram loading dose and 200 to 300 milligram 6th hourly can be started. So you can start propylthiouracil or you can go for methimazole, carbamazole. But propylthiouracil will be a better drug comparing with other one in storm, and this can even be given in pregnancy. That is an advantage of propylthiouracil. Now iodide sodium is available in our country, that also can be given. Then hydrocortisone is another important drug which should be given in emergency room. That can be given 50 milligram orally every 6th hourly, or dexamethasone IV can be given. Cholestyramine also can be given. That is an add-on drug to the main regime that can be given to patients who is having uncontrolled symptoms, but that may not give major benefit to the patient, but that can be added to the regime if the patient does not improve. Okay. Aspirin should be avoided. Okay, so what we have discussed here is it's a important condition. Hyperthyroidism in emergency room is an important condition, but unless until you have a strong diagnosis like hyperthyroidism, don't do thyroid function test. If you do a thyroid function test unnecessarily, what will happen? You can get falsely elevated TSH or T3, T4, that is called as CQ thyroidism. Okay, if the patient come to emergency room with unexplained tachycardia, supraventricular tachycardia, cardiac failure, you can suspect hyperthyroidism. The investigation of choice will be TSH, T3, T4. T3, T4 will be normally elevated, TSH will be low. Okay. The treatment of choice here will be controlling the heart rate and controlling the temperature. These are the two important things which is most important in emergency room. You control the temperature, control the heart rate. Controlling the heart rate, what are the three important drugs you can use? Beta blockers, calcium channel blockers, and digoxin. Beta blockers advantage propranolol is it also crosses the blood-brain barrier. So anxiety, fear, all these things can be relieved. Otherwise, you can go for calcium channel blocker or diltiazem. All these drugs cannot be used or can be used with caution only in like patient who is having cardiac failure. So the ideal drug in this condition will be digoxin. Digoxin only problem is we do not have IV digoxin. We can even give oral digoxin. Bioavailability is almost similar. The only thing is it takes some more time than the IV route. Okay. Thank you.